International College of Dentists. And he is also a member of the International College of Prosthodontics, and he teaches restorative dentistry and prosthodontic for undergraduates and postgraduate students. And his research area are mainly in restorative dentistry and prosthodontics. And he served as the Dean of the School of Dental Science, University Science Malaysia for over 7 years, from 2011 until 2018, and as the Deputy Campus Director of Health Campus for 2 years, from 2019 to 2020. And he is also a member of Malaysian Dental Council, and currently he is serving as Professor of Prosthodontics at the College of Dental Medicine, University of Sharjah, United Arab Emirates. And tonight, Professor Dr. Adam Hussein will present a webinar with the title Maxillofacial Prosthodontics, Hope and Challenges. So, Professor Adam Hussein, are you there?
Yeah, I'm here. Thank you, Dr. Amy. I'm trying to share my slide now. So
Okay.
I share screen, right?
Yeah.
Okay, so can you see the presentation?
Yes, but it's still in, can you do the slideshow?
Yeah, okay, 1 second. Is it okay now?
Oh yeah, now it's okay.
Okay, so thank you very much for the introduction, and also thank you to Professor Dato' Muhammad Ibrahim and Dato' Hao Kim Chuan for inviting me to share my interest about this topic. So I welcome all the participants, either the ICD members or members to this webinar, and I hope that my sharing will also invite further sharing about how do we manage patients that need the treatment, as well as also probably we can have collaboration in the future as well. So as mentioned by Dr. Amy, I am currently at the University of Sharjah, but I'm still lecturer of University Science Malaysia. So the topic today I am going to share regarding my interest in maxillofacial prosthodontics, and of course, in whatever treatment that we do, there are hope and challenges. And the hope is that we are giving patients treatment that will hopefully improve their quality of life and so on. But there are challenges in whatever that we do, and then I think we need to strive for better outcomes as we go along. So as mentioned, currently I am in Sharjah, University of Sharjah, which is about 45 minutes from Dubai. So I'm sure that all of you know Dubai, right? Dubai is the place where the tallest building in the world is located, the Burj Khalifa. So it is in the screen. And Dubai also has, as you all know, many attractions. Difficult to visit all of them because there are too many and sometimes quite expensive as well. So this is a few pictures of one of the attractions in Dubai, the Burj Khalifa. And this is the background of the University of Sharjah in Sharjah, which is one of the Emirates in the UAE. So you can see on the big picture there, that is the health and medical colleges. So dentistry is part of the medical health colleges in other universities around the world as well. And then this is during spring, where, well, I mean, there are flowers and so on. And this is the College of Dentistry. So as you are probably aware, in UAE, because of the desert, then everywhere you can see the dates tree, right? So in front of the college also you can see many dates trees. So any of you are welcome to visit University of Sharjah, and then if I'm still here, try to have anybody who come and visit this place. So why do I choose this topic? As I said before, because there are still patients who need this treatment, and then for those who are involved in this discipline, we are providing hope for patients to overcome, or maybe to provide prosthesis for various defects. And of course, there are challenges how to provide good treatment, how to provide good outcome, especially when we do prosthodontics, right? Because ideally, the prosthesis should be, if not better, should be similar to the tissues that we are replacing. Okay, and obviously, in many treatment, multidisciplinary approach is very important, because it involves many disciplines. We cannot do it alone. We have to rely on other specialties that need to contribute with their expertise in managing various aspects of the conditions. And this is a typical multidisciplinary discussions. I took this picture when I was in UK last time. So every week there will be a meeting, a multidisciplinary team meeting, when they manage cancer patients. Apparently in the UK, where I was located last time, Liverpool and Manchester, there were many head and neck cancer because of the issues of smoking, issues of drinking. So in fact, in Manchester and Liverpool, you can see like almost weekly that they do radical neck dissection and so on in order to manage those cases. So after the surgery, then whatever defect that the patient has, the prosthodontic will have to come in to provide the prosthesis, whatever needed, and also to work with other specialty, for example, the speech therapies and so on, to help the patient get on with their life after the surgery. So I will try to cover some of these subtopics here during this short presentation. Maxillofacial prosthesis is basically a prosthesis used to replace part or all of any stomatogenic and or craniofacial structures. I mean, we can get all the definitions from the GPT, right? The glossary of prosthodontic terms. And maxillofacial prosthetic is basically the branch of prosthodontics concerned with the restoration and or replacement of stomatogenic and craniofacial structures with prosthesis that may or may not be removed on a regular or elective basis. So it can be a removable prosthesis. It can be also a fixed prosthesis. And we all probably know, right, regarding the etiologies of the defect. The defect can be congenital or developmental. For example, that cleft lip and palate is quite common. And now this is still common, even though we have been developed, and also things like tobacco, betel nut chewing in some parts of the world are going down in consumption. But unfortunately, cases of cleft lip and palate still there. Okay, similar to other conditions like what do you call it, the cancer and so on. So cleft lip and palate still around. I remember that we used to go to Indonesia to work together with authorities there to do cleft lip and palate surgery involving the oral surgeon and so on. So in cleft lip and palate, we have the defect that need to be repaired, right? Okay. And the defect can be acquired from cancer, as I mentioned, due to human lifestyle, for example, smoking, bitter nut chewing, alcohol, and so on. And it can be from osteoradional necrosis of the palate due to related conditions. And also from trauma. For example, we have the motor vehicle accidents, gunshot wounds, still prevalence in some part of the world. I took this from a lecture by Professor Rosna in this ICD webinar as well, talking about the incidence of cancer, head and neck cancer around the world. So as we can see, and probably many of you attended her presentation, there are still cases of oral cancer, head and neck cancer around the world. So including Southeastern Asia. So that means there are patients who will eventually need maxillofacial prosthodontic treatment after the cancer surgery and so on. And even I think this cancer is everywhere in the world, but the prevalence probably varies. For example, in UAE, the incidents are not that many compared to some other region due to various factors. But there are still cases around that need treatment eventually. And apart from cancer, as I said, trauma from a road accident is common as well. I took this figure from internet, from World Health Organization. So here it, sorry, I couldn't remember what year was this statistic, but in here it says that here is the riskiest road, okay, road death per 100,000 population. So Malaysia is at number 3 after Thailand, South Africa, and then Brazil, China, and the following. So I don't know whether this is still true with the current data, but I mean, if you look at the picture there, I remember in Malaysia, there are still teenagers who ride on motorbike in that position. So this is very risky, that may lead to accident and then eventually will cause defect to the maxillofacial region. And in the UAE also, the accident is still there, but the good news is that the numbers are slowing from 2016 to 2014. Okay. So because of those defects due to various etiologies, so maxillofacial prosthodontic need to come and then provide prosthesis for the patients. Of course, there are surgeons who are successfully manage those defects using surgery and so on. But there are cases where maxillofacial prosthesis is the only options, okay? And then there are advantages and disadvantages. By having this prosthesis rather than surgical repair, one advantage would be the detection of recurrence of cancer, for example, is easier because you can remove the prosthesis, the removable one, and then we can observe whether there's any recurrence of cancer around that primary site and so on. So the prosthesis can be intraoral and also extraoral. The intraoral, the obvious one is the obturators that obturate the palate, that separate the intraoral and the nasal cavity. And we have extraoral prosthesis. For example, we have the nasal prosthesis, ocular, ear, facial, and also a combined prosthesis involving the intraoral and extraoral. So these are things that some prosthodontists do for those who are interested. And then for those who are required to be involved in managing patients with those conditions. So obturator is basically a prosthesis that we use to close, cover, or maintain the integrity of the oral and nasal compartment resulting from a congenital, acquired, or developmental disease, such as cancer, cleft, and so on, as mentioned before. So this prosthesis will facilitate speech and swallowing, by replacing those tissues lost due to the disease, and also from the surgery as well. So this will reduce, the prosthesis will reduce nasal regurgitation and hypernasal speech, improve articulation, deglutition, and mastication. So obturator can be classified as surgical, that we use immediately after removal of the tumor, for example. Can be an interim while waiting for the tumor site to heal, and after that is a definitive where the patient can wear it for long term to improve their function and their quality of life. So the type reflects the intervention time, as mentioned, and in the process of rehabilitating the patient. So this is one example regarding the obturator. So for those who are involved in this field, so we have the tumor there. So after taking the primary, you have the study model, we can remove this defect here, like making a immediate denture, and then construct the surgical obturator for the surgeon to use it to cover the defect for the healing, and also the patient can use it while waiting for the healing to occur. And after that, we can put the temporary one. Then later on, it can be a permanent, either a conventional or it can be implant retained as well. So these are a classic example of obturator. Okay, so in the interim, for example, during the surgical, after the surgery, we don't need to put any teeth because we want to allow no traumatic what do you call it, pressure to the healing site. So these are the conventional obturators. It can be for fully removal of maxilla, for example. It can be partial. Okay. So what are the challenges with this sort of obturators? Okay. So number one is, of course, the lack of retention, because when you lost half of the maxilla, for example, right? I mean, how can you retain the prosthesis? Okay. And this prosthesis can be heavy, so it can be pulled down by the gravity. So these are among the challenges. So it can be very difficult for the patients to wear, to adjust to this prosthesis. So here, one example, bulky and heavy. So this is one of the issues regarding this conventional prosthesis. And there are attempts to make it hollow, for example, here. But with the hollow one, it can attract other problems. For example, these are the area where you can have like microorganism thriving there that will cause smelly and so on. So there are problems and there are challenges with this sort of techniques. So for the retention, mostly is a conventional. For example, here we are using like a conventional partial denture retention, direct retainers. So that's why during the cancer removal, of course, it depends on the cancer margin, right? But if possible, we try to keep as many teeth as possible. We need to inform our surgical colleague that, I mean, as much as possible. But of course, it depends on the extent of the lesion. And then because the teeth that we manage to keep will become can be used for direct retention. Of course, direct retainers, tissue undercut, and some people use magnets. So these are among the conventional methods of retaining the obturators. And here is the what do you call it, the feeding plate for babies. So just retain through like tapes outside the mouth. Okay. Example of magnet retain obturator. In this case, the defect is quite straightforward in the middle of the palate. So this publication here showed how they used they made a two-part prosthesis that help to retain each other by using magnets. So these are one of the example of how these obturators are retained. Okay. And currently, I think there are many materials. In the past, we used like PMMA and cobalt chromium to construct the prosthesis. But nowadays, well, there are other materials like the hard plastic, for example, the polyether ketone, like and also material like flexible that people try in order to help improve the retention, because this material can be lighter compared to the metal. So here is an example of the hard plastic. I think this is a PEEK that can be milled using the current technology, and then this is a bit lighter that probably help to reduce the effect of gravity and help to retain the prosthesis better. Okay, so these are some of the material that people use. Okay. And there are publications, for example, in this case here, the case report here, sharing about the use of polyether ketone or PEEK in the fabrication of a maxillary obturator. Okay, so they found that this material provided the patient with better adjusted, more functional, and lighter prosthesis. So I think we can explore some of this material and then see whether that can improve the performance of the prosthesis for the patients. So those are the conventional method of retaining obturators, but with the advance of implantology, we all know about implant. Everybody is aware about implant nowadays. So implant can be used to retain the obturators. So in this case, when you still have bone, the alveolar bone that can receive implant, we can use conventional implant to retain the obturators. But in cases that there is no more, alveolar bone, and some, for example, in the case of fully removal of the maxilla, total maxillectomy, then other implant, for example, zygomatic implant, is an option, because this will definitely improve retention for the prosthesis, and by having better retention, that will improve the quality of life for the patients. This is an example schematic diagram of zygomatic implants. So there are centers around the world, and there are surgeons around the world who are providing this treatment. And then I think it is important that we work together with those surgeons in order to provide this type of treatment for suitable patients. So this example of zygomatic implant nowadays, I think, is becoming more widely used compared to before. Okay. So if we look at here, I think without the implant help, then it is very difficult, isn't it? For example, if you look at here, this is like almost, even though it is partial, but I mean, very difficult to get attention here. So by having the implant and then the bar that retain the prosthesis, this really helped to improve the performance of the prosthesis in the patient. So this will definitely help the patient. So then by having that implant and the bar, then the prosthesis will go over that bar, similar to any overdenture kind of process. So by having this, that will really help, because without this, then I think it's very difficult for patient to manage those prostheses. And similarly, when you have total maxillectomy, full maxillectomy, this is even more challenging because there is nothing to hold the prosthesis. So in this case, by having a zygomatic implant, here they place 4 of them, 2 on each side, and then they have the magnet that retain the obturator in place. So this really helped to improve the performance of the prosthesis. So if we can offer this to the patient, in suitable patient, then depending on the survival from cancer, for example, right? Because some patient who came early at stage 1, for example, and then the survival can be long, can be more than 5 years. But of course, even though the survival is short, for example, in the late stage of the treatment, the patient can still enjoy a better quality of life rather than having prosthesis which is not very retentive. And there are many publications evaluating the use of zygomatic implant to retain obturator to rehabilitate patients that needs those kind of treatment. And then I think most of the paper concluded that the implant retain obturator highly improved the masticatory function and or health-related quality of life in comparison to conventional obturators. I think we can understand that, isn't it? Because without the obturators, it's very difficult. Even with normal dentures, the patient still have ridges. I mean, if you have resolved ridges, patient will have difficulty in adapting to the dentures. I mean, in this case, if you have no maxilla, then we can imagine how difficult it will be for the patient, right? So those are the intraoral prosthesis, the obturator, but there are also extraoral prosthesis that prosthodontists will sometimes need to provide to our patients. I took this picture from my colleague's work as well. So Dr. Nafish is a friend of mine who is now in IMU. So his interest is also in maxillofacial prosthodontics. So there are many extraoral prostheses that we sometimes have to provide our patients. For example, here we have like the facial prosthesis, we have the eye prosthesis, the ear prosthesis. This is the combination, the intraoral and the extraoral, and also the nose prosthesis as well. So in general, usually these prostheses are retained by using a conventional method. For example, skin adhesive, any skin pocket that can give undercut and retention for the prosthesis. People use eyeglasses to retain nose prosthesis, and yeah, tissue undercut, similar to skin pocket as well. So what are the limitations? What are the challenges? So sometimes we do get skin reaction to the adhesive, loss of adhesion, especially in humid weather, because Malaysia is quite humid. Some countries they are dry, so probably the medical adhesive works better in dry country compared to a humid country. So poor stability and so on. So these are the usual methods of retaining those prostheses. These are the medical adhesive that are commonly used. Okay? So these are the adhesive. We can still available now because not all patients can afford implant. Not all patients can have implant due to probably the centers cannot provide implants. So at the end, the patient will have to accept the adhesive retained prosthesis. So basically, the prosthesis will be retained on the skin by using the glue, the medical adhesive, and by trying to engage any of the tissue pocket or any undercut. So this is not very what do you call it? Very retentive. And some people try using sunglasses, using glasses. For example, in this case report here, I took from a case report, the use of glasses to retain the nose prosthesis. Okay, so those are some of the methods that people use. Okay. With the advance of implants, similar to obturator, so implant retained prosthesis give better retention and improve the performance of the prosthesis. So if you look at the literature, even in the era of Bronnemark and Albrechtsen, they already started the extraoral or percutaneous craniofacial implants since 1977. So in that time, they used conventional implants. So not really intraoral implant, but almost similar. But probably the size is smaller and the length is shorter. So those implants are used to retain the prosthesis, and also the use of zygomatic implant as well. For example, in this diagram here, implant on the bone around the ear there. So, and then you have a bar similar to making like a bar retain over denture, right? So then the prosthesis will go over the implant implant here. So I think theoretically, because in extraoral there is no saliva, so probably the issue of like peri-implantitis probably less what do you call it, less common outside for the extraoral implant compared to intraoral implant. So for the auricular, so people suggest two to three craniofacial implant, about 2 to 3 millimeters by 3.75 millimeter diameter. So on the mastoid or temporal bone, so then the prosthesis can be placed after the healing, for example, 4 months. It is similar concept to intraoral. So this will help to improve the retention of the prosthesis. I remember that even in USM, ENT surgeon do place implant in suitable patients to retain the prosthesis. So in this case here, so we have the patient lost, I mean, for whatever reason, patient doesn't have the right ear, so 2 implants are placed, and then the bar are connected, and you have the clip over the bar that can retain the ear. So this one really helped to improve retention a lot better compared to the use of medical adhesive. And implant also is used for the orbital. In this case here, 3 to 4 dental implant about this length, 7 to 10 millimeters. So supraorbital rim and or the lateral orbital rim. So the implant are placed here. So the planning, the positioning. I saw this in UK last time. So they use like the CAD cam to make sure that the accuracy is, because these are quite critical area, isn't it? Because above there you have the skull and so on. So by having this implant that can retain the eye as well as the facial prosthesis. So this is the planning using the 3D printing, CAD-CAM, and so on. So this will really help the patient to improve their quality of life. So in this article here, it shares a case report about virtual surgical planning and 3D printing in prosthetic orbital reconstruction with percutaneous implant. So basically, the patient need a replacement of an eye and also the tissue surrounding it. So they use technology, the current technology. I think Dr. Amy last time shared with us regarding the 3D, the CAD-CAM, the printing, the milling, and so on. So in this case, they use that technology to basically provide implant retained prosthesis for the patient. So I think eventually the prosthesis are made from probably same material like silicone and so on, but the method of retention is using implant, and also the technique rather than conventional using the digital technology. This is quite common now because I mean, with the current technology, right, we can do the printing, we can do the milling, and so on. In this case, probably the printing of the skull followed by the next step. So then, using the guide, the implant will place around the socket, and then after that, the patient can have the prosthesis, implant retained prosthesis, and then this is really helpful to the patients. I think if we can offer this, if we have the expertise, if we have the skills and the knowledge of how to provide this sort of treatment to the patient, I think for suitable patient, that can really help to improve their quality of life. Similar in this case here, using implant to retain the prosthesis that can help the patient greatly. For the nasal, the primary implant site for the 2 dental implant is the anterior floor of the nose if the nasal bone were resected or insufficient. Okay. So the implant used to support the prosthesis can be of this dimension, right? Okay. And the use of intraoral dental implant is considered more advantageous because of their greater load capacity. And of course, we need the planning using the X-ray and so on. And also, people use zygomatic implant to help retain the prosthesis. When I was doing my attachment in UK last time, I saw my consultant use zygomatic implant to help retain the prosthesis. So this patient had a cancer in her nose. So the cancer was removed, the nose was removed. And then during the cancer removal, the surgeon also, the implantologist, the consultant was implantologist, a prosthodontist, surgical prosthodontist in UK. So he placed the implant immediately during the cancer surgery. So this is what we call the primary placement. So the advantage is that when the implants was placed immediately during the surgery, then if the patient need to go for radiotherapy later on due to cancer treatment, then the implant should have been also integrated already. And then there are many reports advocating the use of primary technique versus the conventional technique. Conventional means you wait until the surgery heal and so on. The tissue heal, then you put it back. So the idea is that if you put the implant immediately during the primary surgery of the cancer, then the healing will be faster. The patient should be able to have the prosthesis quicker. So this one is after that, the prosthesis was retained by using the magnet over the zygomatic implant. So this is the use of zygomatic implant to retain the nose prosthesis. Similar to this case here, I think this case is already a few years when I was there. So the patient was doing quite well with this sort of implant to retain the prosthesis. This example of the zygomatic implant plus also the conventional implant as well. And there are many publications. This is one of the recent one by Chris Butterworth and the team, published in 2020, looking at zygomatic implant-based rehabilitation for patients with maxillary and mid-facial oncology defect. So they found that during the period of the review, survival rate is from 77 to 100%. And then for those implants who are placed at the time of surgery, it can help to accelerate the rehabilitation, meaning that the patient can have the prosthesis quicker compared to the conventional one. Okay. And they found also that the role of radiotherapy in implant failure has not been fully isolated, because I think the thinking is that if the patient has got irradiated bone, then it is not suitable for implant. So, but this review found that I mean, there are protocols that people use if you have radiotherapy to your cancer site after a certain period, using a certain protocol. People believe that implant can be placed, or that they place implant during the surgery itself before the patient undergo radiotherapy later on. Okay. So the conclusion is that zygomatic implant can be successfully used in irradiated patients. And also, in general, those implants really help to improve functions and quality of life for the patients. So, if you are interested, you can search for the paper. I think it's open access, and there are many studies in that paper that we can use for reference. So nowadays, with digital workflow, I think these things are getting probably more efficient nowadays on certain areas. So I just want to quickly touch on this regarding digital workflow. We all know, right, regarding the computer-aided design and computer-aided manufacturing. So the CAM can be two, right? Can be additive or can be subtractive. Subtractive is milling, additive means the 3D printing. Okay, so we all know this. Regarding the production of crown and bridges using the CAD-CAM, quite popular now. The intraoral scanner is almost everywhere. So I've tried for a few times. So for constructing antenna and so on. So this is how it works. So we basically overcome the use of conventional impression. So which is good for patients who are gagging, for example. And in terms of accuracy, I think there are many studies, many publications showing that the accuracy is getting better and better compared to when it was first introduced to the market. Then 3D printing, I'm sure that many of you know this already, is getting more popular now. And I don't want to, I mean, I've got no time to show this YouTube. You can look at yourself. In this, I think in this YouTube, they shared that in China, they use 3D printing to print a house. I mean, not only printing like a prosthesis, they can print house. So nowadays 3D printing can be very useful. And then people do print using metal nowadays and so on, isn't it? So using the melting, the laser melting, and also the sintering, so we can use metal to print certain component of prosthesis. So this is just illustration example of the use of 3D printing to print the skull and to print the prosthesis. So the indirect method will be to use the data from CT, and then you convert into the 3D images, then the STL file, and then of course you can print the skull, and also the model, and we can use that for the prosthetic work. Okay. One example here, traditionally we need to do alginate impression, for example, right? For example, in this case, the patient lost doesn't have the nose due to whatever reason. Then we need to do like alginate impression by putting the a straw here. Then I'm sure, I mean, for those who are involved in this, we know that the step. But nowadays with 3D print, with the scanner, you can just scan the face. Okay, in this case, we tried in one of our lecture there. You can scan, and then you can digitally remove the nose, for example, or we can just scan rather than doing the conventional method, and then we can print this, and then we can work on it. So 3D printing now is quite common, right? Even in other disciplines like auto and so on, we just print, in this case, just print the model and then construct the retainer over it. It's quite accurate nowadays. So these are among the development that probably will help us in terms of providing, improving our efficiency in making the prosthesis. So one example here, the use of 3D technology. So the patient has got the defect. This one I took from a publication from my colleague, Dr. Nafish. Okay. So conventionally we need to do like a multiple step impression, right? But with 3D technology, we can get the CT scan data of the patient from the archive, and then after that we can use whatever software that is relevant. Then we can either print the model, or we can design the prosthesis on the computer and then print it, and we can just copy this and then make it into a wax pattern. So after that we can try it, and then of course it will go through the normal process of converting the wax pattern into silicone and so on. So these are among the current development. And of course the challenges is still the same: how to make sure that these prostheses are matching the color of the patient's skin, and also how to retain this successfully with the patient. Then comes the use of implant and so on. But how to produce the prosthesis? Nowadays we have a digital method versus the digital workflow versus the conventional method. Okay. In this case report here, I just want to share what my colleague did regarding the use of digital workflow in providing a feeding plate for this young baby. So you can imagine in this young baby, right? You know, if you want to take impression, will be very difficult. And also in patient with gagging, with phobia of impression. So I think with this current digital workflow, it can really help. Okay. So in this case, They use the similar concept, the CT scan data, then convert that into a 3D model, the STL format 3D printer, and then from that we can proceed with the suitable prosthesis. In this case, well, this is the general principle, the CT scan data, then we can design it, then we can print it. In this case, what they do, they print the base of the skull, I mean, from the 3D printing, then they use the conventional method on that model rather than impression on the patient. So from there, they convert this into the normal process, the wax up, and after that using the silicone to provide create the feeding plate for the baby. So this really help overcome the issue of patient that it's difficult for us to take the impression, difficult for us to manage clinically and so on. There are adult patients who are scared of impression. So I think this can help in terms of overcoming those challenges. Of course, the other method will be to give them sedation, but I think this is less risky compared to giving patient IV sedation and so on. The last one I would just want to quickly share with you regarding the use of digital workflow in providing this maxillofacial prosthesis. In this case, they use this 3D technology to provide obturator, and at the same time, they use the 3D technology also to provide hollow obturator. So if you are interested, you can go to this report and see how they do that. So meaning that in this case, they are all like digitalized. So provide obturator for the patient. At the same time, provide the hollow obturator that can help to improve, to reduce the weight of obturator and so on, all done digitally. So, and then this really, help to improve the efficiency in making the process, as well as helping to improve, hopefully, the performance of the prosthesis for the patients. Okay. And lastly, because sometimes the scanner can be expensive, right? If you want to buy a good scanner nowadays, I remember my friend bought it for 70,000, can be very expensive. So in this innovative approach, this group looked at the use of smartphone camera. So in this case, they compare the images from smartphone with the commercial scanner. So in this case, they look at the smartphone versus laser scanner to see what are the outcomes. So basically, they test on ear. So one group is scanned by using the commercial scanner. The other group is scanned by using the smartphone, and they compare the images, the STL cast, and then they found that the accuracy is almost comparable. So if this can be further validated, that means that even in some part of the world where probably some cases where dentists cannot afford to buy expensive scanner, then the use of a smartphone can be explored further in those cases. So I think that I'm coming to the conclusion now. So I just want to say that there are patients in need of maxillofacial prosthesis. I think we all know that due to various reasons. And then I think in this current world, we are very lucky because there are digital technology which are, I think, growing very fast now. We can mill metal, we can mill like hard plastic, we can 3D printing almost various material now. But still, I think whether we produce conventionally or whether we produce using the digital workflow, there are challenges in retaining the prosthesis. That's why implant is important. So I think it is very important that we work together as a team with surgeons and so on, so that there are people who are able to offer like complex treatment, for example, zygomatic implant to the patient. because this will help to improve the delivery of care to the patient, also improve the prosthesis for the patient. So I think at the end, of course, we need to work as a team, and I'm very happy to have anybody to share their experience or their knowledge regarding how do we improve the treatment for this sort of patient further. That's all. Thank you very much to the college for inviting me. Then thank you. I pass over to the moderator.
Okay. Thank you, Professor Adam Hussein, for wonderful presentations, and it's very interesting. And I hope it can help to our ICD member or other dentist who's interested in maxillofacial prosthesis. And also, Professor Adam also mentioned some of the new changes that compared to the conventional prosthesis. And there's also mention about some other material selections from plastic, because it can be wider, such as from PEK or PKK. And there's also implant retain obturator, or also implant retain prosthesis, which can improve performance. And there's also about some limitations if we use a conventional prosthesis, such as the adhesive and also how the retentions. So nowadays, there's also more known about the new advance in technology and the use of a digital workflow. And it can also be used in the prosthesis, extraoral prosthesis or intraoral prosthesis also. So with this new improvement, we also have some new challenges. And this is a very good presentation, Professor Adam. Thank you very much. And to our listener, if you have any question, please write in the question and answer session, because we will have the question and answer session now. But I think there is no questions, so maybe can I ask you a question?
Yeah, sure.
You mentioned about the use of CT scan. So is that a CT scan or is it a CBCT? And there's also mention about the scanner. In the journal, I saw you made a model and then scanned the model. And or do you use a face scanner? So it's about scanner in the digital workflow.
Yeah, I think regarding the data, regarding the data, I'm not sure why the echo is there. Yeah, regarding the data, I think in the case that I showed with you regarding the baby, the data is CT scan. But I think whether we can use CBCT or CT scan, as long as the data can be converted into a 3D model by using suitable software, right? So I mean, it doesn't really matter. So the main thing is that the data must be able to be converted into a 3D model by software, and then after that they will convert into STFR, right? And then after that, of course, you can go for the milling, you can go for the 3D printing and so on. So those, I think that the data can be either one. And regarding the scanner, the one that I use is I can't remember the name of the scanner, but this one we scan directly from the face. I think that nowadays we talk about the scanner. People talk about fully digital, semi-digital, right? For example, that fully digital means you scan directly from the mouth, for example, right? And then partial digital, probably you take impression, then you send to the lab will scan the model, for example. Even people can scan the impression. I remember reading about post and core, right? I mean, some people just scan the post prep directly from the mouth, but there are issues how deep can the scanner go into the post prep, right? So they use like a scan post and so on, but there are still problems in terms of getting the depth of the scanning. So in order to overcome the issues, people use what do you call it, the semi digital. That means they take impression, or maybe they do the wax pattern, then they pour it, and then they scan, or they can even scan the impression itself by using the scanner and then convert into the post space. So I think it is an interesting technology now, but people are still experimenting to probably get a better result nowadays.
Okay, thank you, sir. And there is a new question from Dr. Peng Lang Cheng, and asking about, may I know what is the material used for the skin-related prosthesis?
Yeah, I think at the moment we use the medical grade silicone, right? So after we, I think the silicone is still the gold standard material for the skin prosthesis. So the issue is that whether we can get a suitable colored silicone with people in Asia, because I think that the company that made the silicone is from the western part of the world. So probably the reference is the Western people and so on. But to answer to your question, the material is the silicone. So after we have the wax pattern, we can convert that into silicone, and then that silicone is used for the skin prosthesis.
Okay, good. So if there's any other question, please write in the question and answer or the chat box, and we will discuss with our speaker tonight. And while waiting, maybe I will just ask another question. Is it okay?
Sure. Yeah.
What type of the implant that you use for the extraoral implant retained prosthesis?
Yeah, there are like specific implant that we can get from the company, right? But I think it is still using the osseointegration, right? Eventually the implant will have to go into the bone. So the intraoral implant, I think it is not suitable sometimes due to probably the length is not suitable, the diameter, but I think the principle is still the same. So I think they come up with I can't remember which company that I remember, for example, this Zagomatic is, I think, if not mistaken, by I think if not mistaken, Nobel, I think. But for the extraoral, I think the concept is almost similar, but the dimension is different because you have like probably not much thickness of the bone, isn't it, around a certain part of the what I call it, of the area. So it has to be like certain dimension that's suitable, that can be used in those areas, for example, around the ear and also the orbital and so on.
Okay, thank you, Prof. So there is a new question from Professor Cullum. So he's asking about for a country of 17 million people, how many maxillofacial prosthodontists should there be?
Wow, that's a very good question, right? Yeah, that's a very good question. So, what is the ratio of maxillofacial prosthodontists to population? Even in Malaysia, I don't know how many maxillofacial prosthodontists that we have. To be honest, Prof, I'm not sure. I do not know the answer regarding how many. What is the ratio of a maxillofacial prosthodontist to population? So. But we have to look at also the incidence of, for example, incidence of cancer, right? So it depends on, I think by looking at the incidence of cancer in each country, then we can probably estimate how many that will need this kind of treatment. I mean, of course, we have the cancer, we have the accidents. So, but obviously, I think the number will be less compared to the need for general prosthodontics. I think that will be my response, Prof. Callum.
Okay, thank you. There's also a question from Dr. Sylvia Lehmann. Is the implant has a magnet? So maybe
I think actually the one that I showed there, after you place the implant, the attachment, because if we refer to implant retained overdenture, right? We have the ball attachment, we have the locator, we have the bar. So basically, the implant is just like so any system, any implant system that can what do you call it? Can have implant attached to their implant body that can be used. So implant itself doesn't have the magnet, but I mean after you place the implant, the connection to the prosthesis can be by using the magnet or any other method. So I think any implant system that can have that option, then we can use a magnet for the prosthesis.
There's another question in the chat box. Is the loading protocol for orbital implant similar to the intraoral implant?
Yeah, when I look at the literature, they said that after you place the implant, the waiting, I mean, this is according to the report, right? I mean, it should be about 4 months. So that is the what do you call it? I mean, the good healing period, osseointegration and so on. But if we look at the intraoral implant nowadays, we can have like immediate loading, right? We have like 4-on-4. I mean, you can load implant immediately. And if we think theoretically, the outside implant, for example, if you want to retain the ear, right, with the silicones not very heavy. So with not so much force, I think if we can get good primary stability in the beginning, I would predict that the loading protocol can be quicker. So because there is not much issue of like in the mouth you have the occlusal load, isn't it? That can, I mean, you are loading all the time, isn't it? Because you have to bite and so on. But outside, because not much pressure on the implant, even I think if you look at general implant in the old days, Professor Bronamat suggests that you put implant, you leave it there for 6 months, right? But then later on, people come up with the immediate protocol, immediate loading, and so on. So I think nowadays, with so much knowledge about implant, it can be quicker rather than we have to wait for too long.
Okay, thank you, sir. Is there any more question from the audience? If there is no more question, I will end the session. Is there? Because it's already 10:30, I think. Okay, then if there is no other question, I will finish this webinar for tonight. Thank you, Professor Adam Hussein, for the wonderful presentations. And thank you to all our audience for today. And okay, Professor Ibrahim, will you take the presentation again?
Okay, thank you very much, Dr. Amy, for moderating the session. And of course, thank you, Professor Adam, for sharing the experience. And on behalf of Section 15, I would like to thank you for sharing your experience with us. We hope maybe we can share again in future any other interesting topic with our audience. Okay, as usual, I will announce that our next webinar is on the 22nd of June. Okay, by Professor Yong-Guk Park from Korea. He was from Kyung-hee University on the 22nd of June 2020, and Professor Park will be sharing this topic on management of sleep-related breathing disorder. So please join us again on 22nd of June 2022 to listen to our speaker, Professor Yong-Guk Park from Korea. Okay, thank you very much all for joining us, and thank you, Professor Adam, and also Dr. Amy for moderating, and good night. Thank you.
Thank you and good night.
Yeah.
Thank you.
Thank you.